Good afternoon, good morning, colleagues, ladies and gentlemen. Professor Pikaluga has basically done my presentation, and I thank him very much, but let me say a few words. The science of CML has been actually exhausted this morning from the yesterday, today, and one feels very enlightened. But before I start, I'll introduce my wife, who is here with me, Mildred, my colleagues from the Nairobi Hospital, Fred, Alan, and Grace. For coming to stand here with me. Now, no financial disclosures. In a presentation like this, one, of course, gives a little bit of the life, the beginnings of the journey. And when I was in high school at my A-levels, I was given a prize, a biology prize. And this was a novel called Cancer Ward. I'm sure several of you have probably read this word by Alexander Solzhenitsyn, the Russian novelist. This novel inspired me not only to go into studying medicine, but also into oncology. One looked at the cancer patients in this central Russian hospital being treated, and the difficulties that were being experienced at that time were really heartbreaking, and you felt like if you became a doctor, then one thing that you wanted to become was an oncologist, to touch people's lives. Historical perspective of CML before I go into, but I'll also mention briefly my mentors. Because you don't just get born and one day you find yourself something. When I was in my medical school, I had a very good teacher that I really admired and who took care of me, and that was Professor Thomas Ogada, professor of hematology at the University of Nairobi. And after my studies in that, when I went for my medical oncology fellowship in London, Professor Pikaluga has shown Professor Tim Oliver at the London at that time and St. Bartholomew's, and working with great people like Andrew Lister, and then I got to know, in Manchester, Derek Crowther and the rest, who were very great hemato-oncologists and who really led me forward in this area. Chronic myeloid leukemia has been talked about. When I was postgraduate medical student at the university, we used Myleran for treating this condition and hydroxycarbamide, low-dose cytarabine. But these other medicines, interferon, were out of reach, and allotransplant was not practiced in our country because really, in a low income setting, we couldn't afford it. Now what changed? In the year 2001, and most of you know this, that in a presentation in New Orleans by Dr. Brian Drucker, presenting results with STI 571, and that was really a landmark report. When I went to that room, the room was packed, the excitement was in the air, and in many years of attending meetings, I have not seen so much excitement in the history of cancer medicine, in the discovery and the development of a drug that changed a difficult disease overnight. I went back from that conference. I had lots of patients who were suffering from chronic myeloid leukemia and whom I could not treat with the hydroxyurea and busulfan because they had reached really the end of their responses. And what did we do? I tried to get, the following year, I tried to get hold of this drug. I didn't know where to get it. I didn't know it was a Novartis drug until later on in the year 2004 when I got a call from Axios International in Kampala asking me to become one of the GPAP physicians because this drug had been introduced in our country, but we did not know about it. In the June 2005, I met Pat Garcia Gonzalez and her team of the Marx Foundation, and they actually inducted me into the program that was called JIP Glyvac International Patients Assistance Program, and in August 2005, I enrolled my first patient into the program. And that is why it is now 20 years, basically. We did treat patients, and there was a lot of good improvement. We were all very happy, but of course, as expected, some patients did not do very well, and we struggled. So in 2009, when AMN 107, let me call it that, because that's what we called it at that time, and the gray hairs like myself know that it was not nilotinib, it was AMN 107. It was introduced, but we were not getting it for free, so many patients could not afford it. It had to be bought. And soon after that, we got free dasatinib, bosutinib, ponatinib, and asciminib now is there for patients on a patient request basis. We run the clinics at the Nairobi Hospital and at the Nairobi Hospital Cancer Treatment Center, and since these drugs were given free, I made a decision that we would never charge patients for treatment on this program, that we would treat all of them free. Initially, of course, it looks like the numbers were going to be very small, but I knew that with the time we were going to deal with very large numbers. And so we did treat these patients at the hospital, and we run these clinics on every other Saturday. We are in the clinics every other Saturday from the year 2005. And on average today, we see about 150 to 180 patients at the clinic. The personnel are the medical oncologists and hematologists from the University of Nairobi and Kenyatta National Hospital and the other hospitals around Nairobi, particularly those who have come through our medical oncology fellowship program. The pharmacists and nurses, these are personnel employed by the hospital, and we have also coordination from personnel from the Marx Foundation, and then there's the patient group called HENSO. We also get visiting consultants from time to time, and there you can see on a clinic day, Professor Pikaluga has shown more pictures, and the team, and also Dr. Gianluca Cristiano, also from Bologna, who come from time to time visit us and week clinics. And that is a picture of the Nairobi Hospital. At the clinics, there are talks by patient representatives, there are questions and answers. There's counseling on compliance, nutrition management of side effects and medicines, the education on CML journey by the healthcare personnel, and then we do the consultations, and then we do prescriptions, and we discuss complex cases. Now, this is a typical clinic day. To my right, on the left, is Professor Mwanda, professor of hematopathology, who really has been very, very determined. We have worked with him over the years. Other people more recent, and that on the right is the clinic day. There are many patients, and they are treated by the hospital free. What did we do during the COVID era? Because during those days, patients could either not travel or the hospital was not ready to take large numbers of patients. So what we did is the team sat again on Saturdays, received blood results from patients wherever they were. We sat down in the hall, looked at the files, discussed them, looked at the results, looked at the progress, and decided on the drugs that were given. We wrote the prescription, taken to pharmacy. The pharmacies then dispensed these medicines and sent by courier service to the patients where they were. This we did until the end of COVID. We did a Kenya CML registry. This was a collaborative effort between the hospital physicians, the Ministry of Health, National Cancer Control Program, the Kenya Society of Hematology and Oncology, and it was sponsored by Novartis Pharmaceuticals. From this registry, I did present a poster at the 2023 ASCO meeting on the report of chronic myeloid leukemia registry in a low and mid-income setting. By that time, we had treated 1,347 patients. The males, slight male preponderance with an age range, median age at about 43, 44. And if you look at that on the right, that's the map of our country, Kenya. And these are the areas the patients came from. This is the high population areas. One cannot say that these are high-risk areas, no. These are high population areas, and these are the areas where the health facilities that have the capacity to make a diagnosis and treatment come from. The northern part of our country usually is densely populated, so one is not expecting terribly many numbers. At the same time, as is expected, we also serve patients from the other parts of East Africa, particularly in the East Africa community area. There are programs in Uganda, Tanzania, Ethiopia, but sometimes patients who come from closer tend to prefer to come to our centers. Now, these are from the total number, by the time we did the registry, about 10% had died, 1.7% had been declared failing, and 0.2% had been pregnant. But pregnancy now, we have larger numbers, and pregnancy in CML is a different topic which we cannot discuss now. We start them on imatinib as the standard drug. Second line has been dasatinib. Dasatinib side effect profile tended to be a little softer than the other second lines, the other second generation TKIs. So we tended to use dasatinib more. We had access to ponatinib, which we have really tried to keep because this is really our goalkeeper. If everything fails, we go to ponatinib. And so we have used it mainly as third line. Ponatinib, yes, has been mainly third line, but even then we still we have used dasatinib a lot more. As I said, we have tended to reserve ponatinib. Initially, the side effect profile of ponatinib was highlighted, but during the time we have used this drug, we have found it to be dependable with a fairly low side effect profile. Initially, when we didn't know how to use it, the first 2 patients we put on ponatinib did not make it, and we were alarmed. But then we quickly learned how to use it, and now it is one of our best drugs, which we use in this condition. There has been transformation, again, by the time of the registry, 1.9%, but these numbers are more. Blastic was at 27.8%, and this was mainly myeloblastic, as expected, but again, these numbers are subsided. And there have been deaths, and again, these deaths are underreported because the numbers are now larger. Because of the distances, we decided to devolve with a collaboration with the government of the Republic of Kenya coming in. We decided to devolve to the western part of the country, to the coast, and also to another area in Nairobi so that patients could get treatment closer to where they came from to cut down on the cost of transport. But apparently patients still prefer to come to the center at the Nairobi because the Nairobi Hospital, being a private facility, arrangements are different, and patients find it a lot more convenient. Because of this work, really, we felt Pat Garcia, the CEO of Max Foundation, I believe, whom all of you know, deserved a recognition, and there is Pat being recognized one of the Heroes Day 2023 or 24 by our president, and the medal that she was given is there in her hands. We have had challenges in that mutation testing. We had selective mutation testing several years back, but the lab that was doing it did not find it to be commercially viable, so they closed it down. So now we get the panel, the complete panel, and that is expensive for many patients, so we don't get routine mutation testing. Regular quantitative PCR analysis, again, some patients still find it expensive, and from time to time we also get that the laboratories don't give us what we expect, so we quarrel with them. The devolved units are not so popular because they run in public facilities, and patients prefer to come to our facility, which is a private one, where they find they're a lot more comfortable when they come. And then there's that exponential increment in patients' numbers. As they survive longer, the numbers are much larger. And this is going to overwhelm not only the facility, but also the service providers. And then we find that the service providers tend to get sometimes exhausted, and you have to keep really encouraging them to just go the extra mile. We are trying to overcome these challenges by establishing research projects which can have some funding to help decrease laboratory costs, strengthen medical oncology fellowship program, which is really what we depend so much on, these fellows at the University of Nairobi, strengthen the satellite clinics so that the hospital administrators there recognize that the doctors who run these clinics have the duty so that they are not given too many other extra duties, and also negotiate with manufacturers of cheaper generics of the drugs. Like now, dasatinib, we are getting low on dasatinib supplies. So to conclude this, the patients with CML in Kenya have benefited from donation by the charity, and that is unparalleled. Physicians and other healthcare workers at the Nairobi Hospital translated the donation into a success story, clearly demonstrating that going the extra mile matters, and sustainability is in focus. We have to work very hard to sustain this. And I want to acknowledge my family, the Marx Foundation, Novartis, the Pfizer for bosutinib donations, BMS, dasatinib, Takeda for ponatinib, the Nairobi Hospital, the doctors, the pharmacists, the patients, Henzo, the government of the Republic of Kenya, the National Cancer Control Program, the Kenya National Cancer Institute, and the International CML Foundation. I have been saying this over the years, and I am not going to be shy about saying it. Had I had my own Nobel Prize, the lecture that Brian Drucker gave that day in New Orleans was remarkable, and if I had my own Nobel Prize, I would hand it over to Brian Drucker today, and another one to Pat Garcia Gonzalez. And I want to thank you very much for listening to this presentation. Thank you.
Thank you very much, Professor Abinya, for this presentation, for squeezing 20 years in 20 minutes. Any question or comment? If not, may I start with one? I'm quite impressed by some differences that I noted and you referred about many times about how drugs, they behave in Kenyan population in this particular example. We know from tamoxifen experience that pharmacogenetics in African population is different from what we have. And most clinical trials and even real-world experience are published from Western countries, now something from Asia. But we really don't have many data from Africa. Now, we noted that, for example, ponatinib is, I think, much better tolerated in Africa. This was my experience. It's like a very, very smooth drug. Do you have first any idea for studying that, or are experience with other drugs that you see kind of paradoxical, better or more toxic effect in your patients?
Thank you. The toxicity profile that we have problems with bosutinib can be quite heavy. In terms of initial 2, 3, 4 weeks causes quite a bit of diarrhea, but we have learned how to cope with the diarrhea. The other one is mainly bosutinib, really, which gave us problems. As I said, ponatinib did crash for us the counts when we started it at the dose of 45. So what we have done now is we have, for those with cytopenias, we have tended to start with a low dose and build it up, as opposed to the standard practice of starting with that standard 45 and playing downwards. We have done it the opposite, and we have no trouble with ponatinib. In fact, taking imatinib tends to be slightly more difficult in that the do's and don'ts with imatinib are a lot more than the do's and don'ts with the dasatinib, ponatinib, and the rest. Yeah.
Thank you. We have a question.
So, very great talk, a great experience. I'm here.
Yes.
I just noticed my picture on your slide, so 2023 at the ASCO meeting. Do I look the same?
Oh, no, I can't see you. I can't see you, but I'm sure that,
Okay.
I'm sure you have that.
Great honor here. Actually, I'm the co-founder, chairman, CEO of Ascentage,
Okay.
the developer of olverembatinib. So I will make sure olverembatinib will be available in Kenya. So next time you can put olverembatinib on your list.
Thank you.
Thank you.
Thank you very much.
So I'm Hemant Malhotra from Jaipur in India, and I can very well relate with what you've just said, Professor Abinya. My question to you is, do you have generics in your country? Because generics in my country, made in my country, are a lifesaver for so many patients of ours.
Yes, we have the generics, but since we have particularly the ones where we have the original ones, and we get them to the program free, we have not been very keen on getting the generics. But where the supplies, because I know some of them now are reaching the end of the period that we are given. When we reach that stage, we are now beginning to see how we can negotiate with the generic firms to supply for us, even if it is at a smaller cost, but it's far better than buying the originator molecules at a very high cost, because in a low-income country, they can't afford. They can't afford it. And we have many patients now. And people know the program is there, so they will not take it lying down that they have had medicine for 10 years, and now you are telling them you cannot continue giving it to them. It is difficult. Yeah.
Thank you.
Thank you.